Okay, thank you so much. So, yeah, first and foremost, thank you to the eminent gynecologist from South Gujarat for inviting me for this talk. And it's really a pleasure to have a cross talk. I always enjoy talks where you have more than one specialty dealing with the topic, because then it becomes a dual learning channel, right? It's a learning process for me as well. I get to see a lot of interesting perspective from the other end of the spectrum. Yes, ma'am. Yeah. Okay. So, yeah. So, okay, ma'am. So, thank you so much for having me. And like I said, it's really a pleasure to be a part of a crosstalk where you have more than one specialty dealing with the same objective of improving the life of our patients. So today we are going to talk about an approach to patients with premature ovarian insufficiency. Now, this word, this is the brief overview of the talk. So we are going to see an overview of POI. We'll see what a clinician needs to know. At every point of time, I'm going to give you my perspective, that is an endocrinologist perspective to POI, which is of course, the basis of my talk today. We'll also look at the symptoms, the diagnostic workup, and finally the long-term consequences and treatment of patients with POI. So the word POI has undergone a change over a period of time. There are many terminologies which have been used for the same disease. So we have used terms like primary ovarian insufficiency, premature ovarian failure, and finally the ESHRE guidelines have tuned to say that we should call this premature ovarian insufficiency. That's the terminology which we now use. So I would request that all of us are on the same panel, same pane when we discuss POI, and we should all call it premature ovarian insufficiency. The reason why this terminology has been decided is because, one, failure is a wrong term to use, right? We should, it's a negative connotation. Failure means that it kind of signifies the failure at the level of patient, which is not the case. This is a physiological condition, and it should be dealt physiologically. So it's insufficiency and not failure. And secondly, the ovary does not completely fail. There is a partial failure of the thing. We never call it adrenal failure. We never call this hypothyroidism thyroid failure. We call it adrenal insufficiency. Why? Because the adrenal gland is not able to produce enough hormone. The same way, it is ovarian insufficiency and not ovarian failure. And secondly, the terminology primary was a little confusing, because if there is a primary condition, then there must be a secondary condition, and we don't have a very well established terminology called secondary ovarian failure or secondary ovarian insufficiency, because that's a debatable area, and that would some people would consider that as involvement of the higher centers like pituitary or hypothalamus, but again that term is not very well defined. So we have narrowed down to the term which is basically premature ovarian insufficiency, and that's the terminology I'm going to use for the rest of the talk. Secondly, we need to have a more solid definition of this condition. The reason why we need to have a definition is because if we have a well-defined condition, then more research can be done on the same topic, and again we are on the same page as far as research is concerned. So currently, again, the European Society for Reproductive Endocrinology has come up with a very well-defined definition for POI. The definition is very clear. You need to have an FSH level measured on day 3 of the menstrual cycle, if you have a menstrual cycle in first place, which is more than 25 on at least 2 separate occasions, at least 4 weeks apart, with a concomitant low estradiol level. At least the level should be less than 50 picogram per ml. Along with this, the patient should have amenorrhea for at least 4 months, and all this should be applicable to women less than 40 years of age. So this is the current guideline, current definition of POI. And again, we request all of us to be in the same page as far as defining a patient of POI is concerned. Now, in future, I would like to see AMH also included as a part of definition, but at this point of time, the problem with AMH is that the assay is not standardized across the world, and hence having AMH for a standard definition is a little difficult. But all of us in practice know that AMH is a very useful test for defining premature ovarian insufficiency. Again, patient has clinical symptoms and signs of POI, and a lot of these patients have amenorrhea for more than 4 months, along with a hypoestrogenic status, along with higher gonadotropin levels. Now, the important endocrine perspective at this point of time here is that often patients with POI, how do they present to an endocrinologist? So to an endocrinologist, these patients often present with non-specific symptoms. So they can have symptoms which are like having hot flashes, or they might be diagnosed to have type 2 diabetes. This is something very important. Again, endocrinologists as well as gynecologists need to understand this fact very clearly. To have a patient with type 2, a classical type 2 diabetes before the age of menopause is not something, it's of course becoming more and more common these days, but it's something where you should have one red flag of a possibility of the patient having a POI. Type 2 diabetes is, and we often seen patient pre-menopause, before menopause and after menopause, and immediately there is a jump in the HbA1c, there is higher insulin resistance, there is higher likelihood of the patient developing type 2 diabetes. So whenever I see a young female less than 40 years of age having type 2 diabetes, I often do an AMH in this condition. And again, AMH is very important for an endocrinologist because AMH is one test which can differentiate two conditions which both present with oligoamenorrhea. One is POI, where you will find an AMH on the lower end of the spectrum, and the other is PCOS, where you will find a AMH on the higher end of the spectrum. So this is where AMH is a very important test. And again, if you see a young female with type 2 diabetes, of course, these patients diabetes needs to be managed by an endocrinologist, but I will also request to get an AMH done before you refer the patient, because that's a very useful thing to really look at when you see a patient. Again, if I see a patient, young female with coronary artery disease or a cardiovascular event or a stroke, again I am looking at a possibility of the patient having POI. So this is where these patients often come to an endocrinologist, and this is where we often make a diagnosis in this case. Also, and something which is very important, patients with long-standing hypothyroidism, so autoimmune thyroid disorders, what we do is that we often look at these patients, the AMH of these patients, because it is very well known that autoimmune diseases coexist together. And whenever we have a patient with hypothyroidism, autoimmune hypothyroidism, Hashimoto's, we often find these patients also having early menopause. It may not be a classical POI, but often their menopause is much earlier compared to the general population. Now, how common is POI in India? In the Western population, the average is slightly lower than what is reported in India. In fact, the numbers may be much higher in India. It might be still a level of underreporting here. The prevalence of POI from various studies done across the country is 5.5%, which is a big number considering the proportion of patients with the large population of our country. 5% of women less than 40 years of age having POI is a big number. In the West, however, in the Europe, the reported prevalence is only 1%, which is, you can see that the prevalence is much higher. Now, in the beginning, Ma'am talked about the possibility of what is the reason why we have more POI in our country. We don't really know, right? Is it possibility because of some exposure to endocrine disruptors, or is it a genetic makeup of a population? We don't really know the reason for that. So there's no clear reason for it, but what we do know is that the prevalence is 5 times higher than what has been reported in the Western population. Overall, again, if you see the incidence in terms of age, less than 20 years of age, the incidence is 1 in 10,000, and this is where we generally look at patients with Turner syndrome. So that is again the group. Remember, Turner syndrome is also a form of POI, a very classical form, but it's nonetheless the form of POI. And as the age advances, so if you're looking at after the ages of 20 and so on, we are looking at more of a possibility of having either an autoimmune disorder or maybe some exposure to endocrine toxins, which can lead to POI. So what are the long-term consequences of POI? You again, like I told you, whenever you have one autoimmune disease, you always have a possibility of another autoimmune disease. And this is something very important. I would request all the gynecologists listening to this talk. One very important condition where you have POI is something known as autoimmune polyendocrine syndrome. Now, a lot of people believe that APS is rare, but again, like we saw that the prevalence is much higher of POI in India. The same way, the prevalence of APS is, we believe, to be much higher in India than it has been reported. The reason why is that often we believe that there is an underreporting of these conditions in our country, and hence we are not able to make a diagnosis. So whenever you see a patient where you are suspecting an autoimmune POI, and how would you suspect an autoimmune POI? When you have patient already having other autoimmune diseases, like for example, patient already having autoimmune hypothyroidism. In such patients, it is very important to look at the other autoimmune disease which could be life-threatening for these patients, and this other autoimmune disease is adrenal insufficiency. We'll discuss this in a few minutes again, but at this point of time, there is something I'd really like to bring to your notice. Adrenal insufficiency can coexist with autoimmune POI, and in that scenario, remember, adrenal insufficiency is very, very underdiagnosed, and often this is a life-threatening condition where these patients often can come to an emergency in a adrenergic crisis, and a lot of the times this is not even diagnosed. So this is the sad aspect of this condition. So we'll look at the in more details in a few minutes. Often they have impact on bone health. Remember, osteoporosis is very common in India, and again, osteoporosis, remember, is the primary cause of osteoporosis is the lack of estrogen hormone. And when you have early menopause, the earlier it is, the more likely you are to develop osteoporosis, and the consequences of osteoporosis is actually very severe. Again, this is something which a lot of people underreport and under-recognize, but remember, the mortality associated with fracture neck femur in our country, or in fact worldwide, is much more than the mortality reported with breast cancer. So fracture neck femur kills more women of the older age compared to breast cancer, and that is something which we often do not realize. And fracture neck femur can be prevented by early recognizing osteoporosis and treating it on time. Again, these patients have genitourinary tract symptoms. They have vaginal dryness, which can lead to painful sexual intercourse, itching, irritation, recurrent urinary tract infection, sexual problems, and so on. Overall, the mortality of these women is reduced. There is reduced life expectancy and often a reduced risk, increased risk of premature death. There is cognitive impairment. Again, very important. Remember, this is the group of women who are in an age which is a productive age. We are now looking at, we all want women to be extremely productive from a work point of view. We want them to be involved in the economy of a country. They want, in fact, a lot of economists have said that by just increasing the women's participation in our economy, we can make a huge impact in our country, which we often miss out because a lot of these women, may have unrecognized POI, and we don't realize the effect of this on their productivity and on their work. What about cardiovascular risk? Now, this is something which I feel is again very, very important. Remember this point, and again, if you don't take any other point from this talk, but this one point you have to remember. Women with POI have much higher, almost 7 or 8 times higher risk of having a cardiovascular event compared to women having menopause at a normal age, or compared to women of the same age not having menopause. So women with POI tend to have much higher cardiovascular risk. And what is very interesting and what is very, very important is that many studies across the world, including the classical studies like the Women's Health Initiative and the Nurses Health Program and so on, all these studies have shown that by giving hormone replacement to women with POI up till the age of natural menopause, which is approximately 50 years of age, you actually reduce the risk of cardiovascular disease in this women by significant number. So in women, so there is a subgroup here. So younger women who are given hormone replacement therapy, there is significant reduction of cardiovascular disease. In fact, the impact of hormone replacement therapy is much better compared to other drugs that we use for cardiovascular disease prevention, like statins. So compared to statins, also compared to your standard rosuvastatin and atorvastatin and measuring of cholesterol and lipid profile and LDL and so on, the impact of HRT is much, much better in terms of cardiovascular risk protection. So I think this is a very important point. We should not be denying these women with HRT because of our preconceived notion that it has negative impact of cardiovascular disease. In fact, it is exactly the contrary, including in studies like Women's Health Initiative, including in that study as well, it was shown that younger women with POI would have much more benefit in terms of cardiovascular protection. Of course, there is psychological well-being and quality of life, which is of course better in these women. Overall, What are the consequences which we already discussed? There is cognitive decline, there is negative psychological feeling of well-being, and there are sexual and genitourinary functions which are often. So these things go under the radar, and they are not often come out in the open. They are often discussed with the doctors, but again the common public do not realize the importance of this. What about fertility, right? And these patients often, to an endocrinologist, they come with the things which we talked about, but to a fertility specialist or to a gynecologist, they often go with issues of fertility. So those women planning for a second child, at this point of time, they'll often face the issue of fertility. And there is, again, remember, however, even in POI, so remember there are two forms of POI. There is something known as overt POI, where you have amenorrhea, but there is also an occult POI, where you have lower AMH value, higher FSH value. So there is reduced ovarian reserve, but these women continue to have menstrual cycles, and these women can have a small chance of spontaneous pregnancy also. So this is something, again, you can keep in mind. Pregnancy rate with autologous oocytes not usually enhanced by fertility treatment. So again, there is again an issue there. So overall, in terms of fertility, of course, this is something which I'll leave it to fertility experts to discuss. But ovum donation is actually the only perhaps the best way of doing it. But then there are other issues here, which I think we'll leave it for now. What about the etiopathogenesis? We discussed this briefly earlier. It could be idiopathic, it could be autoimmune, it could be inherited conditions, iatrogenic, and infections, which can lead to all these conditions. Now, the most important conditions, I'll discuss it out. We'll not discuss each and every etiology because that will take a long time, but the ones which you really need to understand. First and foremost, you need to understand Turner syndrome. And Turner syndrome can be a classical Turner syndrome, which often present in childhood. So we have a lot of patients with Turner syndrome. Turner syndrome is a condition managed by endocrinologists, and we often see a lot of Turner patients in our practice. And generally, a classical Turner patient often presents to an endocrinologist with two things. One, they present with short stature. Second, they present with, of course, primary amenorrhea. So these are two conditions where they often come to an endocrinologist. And again, apart from that, there could be other features. In fact, another very interesting thing I'll tell you. A lot of these girls are first diagnosed to have thyroid dysfunction. They are often diagnosed to have hypothyroidism, and then later we do a karyotype, and they are also found to have Turner syndrome. Remember, autoimmune diseases are also much more common in patients with Turner syndrome. It's very, very important point you have to understand. So a lot of these girls are first diagnosed to have hypothyroidism by their pediatrician, then referred to an endocrinologist, and when the endocrinologist sees the patient, they say, oh look, this is Turner, right? And we often do a karyotype and find a Turner. But there is often a mosaic Turner. So there are variants of Turner syndrome, which is where you often have normal menstrual cycles. Often these women may also have children, so they often conceive spontaneously also, and these are milder variants depending on how their chromosomal aberration is. So these are mosaic Turners. These are the patients who go under the radar, but they tend to have early atresia of the ovarium, and often they tend to present with POI. And remember this point, a karyotype must be offered in all women with POI, right? No matter what the age, right? So we have in fact diagnosed just a few weeks back. I had a patient at the age of 36 who presented with POI. We did a karyotype. Now the only thing is, this lady did not have any children. She was married but did not have any children. They had undergone some fertility treatment in the past, but we did a karyotype and turns out to have mosaic Turner at 36. And I'll tell you one more, even more very sort of an interesting case we had when I was doing my residency. We had a lady at 55 years of age with short stature. In fact, you see her, we expect to see these children at 12 years of age, but we are seeing a Turner patient at 55 years of age. She never had periods in her life. She never married. She had many cardiovascular events, which nobody bothered to check. Why did she never have periods in her life? Why did she never marry? Why did she never have children? We at age of 55, for the first time, we did a karyotype, and she had a classical Turner syndrome. Now it was very surprising that she survived to this age, but this is what happens. Often we miss out diagnosis even at late. So again, what you have to keep in mind is that karyotype must be offered, and also something very important in today's world, you need to ask your geneticist or your lab to also do a FISH to look for Y chromosomal material. This is very important. A lot of these women have what is known as a gonadal dysgenesis. So they have some Y chromosomal material. So it's not a classical Turner, it's a variant of Turner. And when you have Y chromosomal material, this is important because that the gonad which you have, it's basically not just an ovary, it's ovotestis, and this gonad can often develop malignancy. So if you have a Y chromosomal material, these women should undergo bilateral oophorectomy or whatever gonadectomy they have to remove that, because that is it is at a risk of developing gonadoblastoma or a malignancy at a later date. Then you have fragile X premutation. Again, a very important condition which must be done, especially those dealing with fertility issues. You need to check for FMR1. You need to do this because remember, this has consequences for the later life also. Those women who have premutation, they are likely to have offsprings who have fragile X mental retardation, the classical condition which they can have. So again, FMR1 must be checked. Again, I understand a lot of fertility specialists are already well aware of this and also in the loop for this. 17 alpha hydroxylase deficiency is again an endocrine condition where patients present with clinical features like POI. So these are some of the important conditions which you need to be aware about. But apart from that, autoimmune disease is in fact a very important cause of POI. And like I said, when you have a patient with autoimmune thyroid disorder, which is a big number, if you have these women, and if these women are having menstrual irregularity, oligoamenorrhea, amenorrhea, it's very important to look at the AMH and FSH and to diagnose POI, because a lot of these women will have POI. And that is again responsibility of your endocrinologist to understand this, that when you have a women with autoimmune thyroid disorder, you can also have these women having POI. Also, second important thing which I talked to you about in women with autoimmune disease, there is a test which, of course, unfortunately, this test is not easily available in all the labs. But earlier it was not available at all, but now it is available. It's available. I'll name the lab because it's the only lab which is available. It's known as a Quest lab in Gurgaon, and there is a test which we do which is known as 21 hydroxylase, NT21 hydroxylase, antibody. And this 21 hydroxylase antibody is very important because 21 hydroxylase antibody is seen in both POI, and also these women tend to develop autoimmune adrenal insufficiency. So if you have this antibody positive, I don't say that you do it in all your women with POI, but this is at least for those women where you feel that autoimmune etiology is very likely. It's a very specific test for autoimmune adrenal insufficiency, also very specific test for autoimmune primary ovarian insufficiency, premature ovarian insufficiency. So both for POI as well as for adrenal involvement, 21 hydroxylase antibody is a very important test. So if you do this test and if you find this antibody to be positive, these women should be under close observation of an endocrinologist, because these women can develop adrenal insufficiency. We have a lot of the times we have retrospectively diagnosed patients with adrenal insufficiency. A lot of our thyroid patients are diagnosed to have adrenal insufficiency. So again, it's very important to recognize primary adrenal insufficiency, also previously known as Addison's disease, because this is a life-threatening condition, and if this is not recognized, these women, if they have any physiological stressful event or perhaps COVID or something, they will not survive, because adrenal insufficiency is a potentially dangerous, life-threatening disease. So this is something you need to be aware about. Of course, infections and drug-induced or toxin-induced POI or surgical menopause, all these things you are again very well aware about. Okay, we'll not go into too much details about the mechanics of POI. Again, this is something which we can leave it to perhaps a more theoretical discussion in the future. But like I said, we already discussed issues like autoimmune, which is an important etiology, and it happens about 4 to 30% depending on the case series which is being seen. There are other risk factors, and one very important risk factor which is something again we don't discuss too much in our practice, is smoking in women. And again, smoking is an important cause of, it's not only important cause of POI, but it's also an important cause of early menopause. So those women who smoke, it's an important cause. Nulliparity, family history of menstrual abnormality is important, because again, a lot of these are genetic conditions where you can have perhaps a genetic transmission. Chemical exposure and genetic factors, these are all important causes of POI. But I'll pause a minute on chemical exposure. And like I said, one of the reasons which has been proposed for increased prevalence of POI, one is often it could be because we are diagnosing more people. That is very easily the cause. But the second reason is perhaps that we are all exposed to endocrine disruptors. Now, I'll tell you a simple example of an endocrine disruptor. I don't want to scare you, but just I want to show you. Now all of us go to restaurants or to shopping malls and all those things, and we often ask for this receipt which you get when you're that at the end of your billing, you have this billing receipt, and the billing receipt, the ink which is used, that has been known to be an endocrine disruptor. This is as simple as that. Plastics, the plastic bottles, of course these are now, there are a lot of regulations behind it. In Europe, of course, they are very strict about all these endocrine disruptors, but bisphenol has been present in a lot of these chemicals, and including plastics, including these receipts, all these things. And the bisphenol has been known to be an endocrine disruptor. It has estrogenic like properties. It often leads to follicular atresia as well. So endocrine disruptors are very important. And remember, our children, they are playing around with these receipts. They are going to to shops and to malls, and I mean, who really knows what are they really being exposed to? So these are all some important unknown unknowns which can lead to POI. We don't know much about it. In fact, the endocrine community is now a lot of research is being dedicated towards understanding endocrine disruptors, and that's the next big thing as far as endocrinology is concerned, to understand the environmental toxins which can lead to endocrine diseases. What are the clinical presentations? Like I told you, how do these patients present to me? These patients present to me, they are often having thyroid disorders. They have been on my follow-up for a long time, but they present to me with then of course secondary amenorrhea, and of course we rule out pregnancy, as we all know, but they often present with secondary amenorrhea, or they can present with oligoamenorrhea, and we often look for AMH and FSH in these women. These women also present to an endocrinologist with newly diagnosed diabetes mellitus, type 2 diabetes, and again this is where we think of possibility of a POI. Often they present to gynecologists with again amenorrhea, either primary or secondary, menstrual oligoamenorrheas, menopausal symptoms like hot flashes, vaginal dryness, psychological disturbances, sleep disturbances, and so on. Again, vitiligo, very common. Again, it's another autoimmune disease, and this again, vitiligo is strongly linked with other endocrine autoimmune diseases. So if you have a women with vitiligo, in fact, I had a South Indian lady, which I just saw her yesterday, so I'm just reminded of the fact. We had a South Indian lady who presented with hypotension, who had her son was dark skinned, but this lady was having vitiligo, and she was there's no pigmentation at all, very severe loss of pigmentation throughout, and this lady had hypotension, hyponatremia, and we evaluated her, and she is found to have adrenal insufficiency. So often you have these kind of things which you often miss out because of the skin color. Ideally there would be severe darkening of the skin, and somebody would have easily recognized her, but the diagnosis, but because she had vitiligo, again there's an issue, right? They often have autoimmune hair loss like alopecia. Often clinically they'll have a goiter, fatigue, anxiety, depression, and so on. So there are a lot of studies which have shown that there is increased all-cause mortality in women with POI. Cardiovascular mortality is also increased in these women. Overall, if you see, these women have genitourinary symptoms, poor quality of life, increased cardiovascular risk, increased risk of osteoporosis, fertility, of course, and higher mortality. All these things are important, right? Clinically, of course, like I said, when you have, so let's look at the other way. If a woman presents with POI, she's diagnosed to have POI, what are the things you need to investigate? You need to do a karyotype with Y chromosomal fish for Y chromosomal materials. This is my typical thing. We do a chromosomal analysis karyotype with fish to look for Y chromosomal material. This is what I advise, and most good labs with genetic facilities available, they do this. With karyotype facility available, they do this. Look for other autoimmune diseases like hypothyroidism, adrenal insufficiency, type 1 diabetes maybe, right? In fact, again the other way around, type 1 diabetes, girls with type 1 diabetes often tend to have POI. So it's again known to have. They'll often have history of recurrent pregnancy loss, luteal phase defect kind of features, symptoms of fatigue, weight fluctuations, and so on, and newly diagnosed to have metabolic disorders like type 2 diabetes or pre-diabetes and so on, right? So this is, like I said, the diagnostic workup. The first thing, of course, you do with any women with secondary amenorrhea, you rule out pregnancy. Then you do for a day 3 FSH and estradiol levels, AMH. You can look for karyotype, like I said, very important, and look for FMR1 pre-mutation. Thyroid function test, anti-TPO antibody again, but 21 hydroxylase antibody, like I said, is a very important test. If you can do this, Quest lab in Gurgaon does it. You can order for this test. You can ask your local lab to connect with them. They often send samples across. You can do a transvaginal ultrasound to look at the enteral follicular count and so on. A DEXA scan must be done at baseline. So if you're a diagnosed patient with POI, do a baseline DEXA scan, and then if you're replacing with hormones, then you can repeat it every 3 to 5 years. Rule out. So these are all the things you need to do for the diagnostic purpose. So biochemically, you'll have higher FSH and lower estrogen, which is what is known as hypergonadotrophic hypogonadism. AMH, of course, is very useful, but the problem with AMH is that the assay needs to be standardized. But at least across Gujarat, we have a good assay. You can do a pelvic or transvaginal ultrasound. You look at the ultrasonography, where you find thin endometrium, less than 4 mm, which is suggestive of hypoestrogenic status, lower enteral follicular count, and so on and so forth. However, of course, radiological imaging is not necessary for diagnosis. Sometimes you have oophorytis, where you have enlarged ovaries also. So again, sometimes you could be mistaken as far as that is concerned. Further, like I said, AMH is the best test for looking at the ovarian reserve, and it has clearly a good thing. But of course, it may not be the only test, right? So you could consider doing further evaluation as well. Now let's look at a brief about, of course, the next talk is going to be a detailed discussion on hormone replacement. But right now I'm going to talk briefly about what is the goal for hormonal treatment in POI, and this is something you need to be very well aware about. So basically, the idea is to mimic the levels of sex hormone, which equates to E2 levels. It's about 100, and once it is initiated, it should be continued till the age of natural menopause, which is approximately 50 to 51 years of age. Now, so I don't really understand why we are even discussing this. There's absolutely no reason why you should not give these women hormone replacement. A woman at age of 35, if she loses her estrogen and progesterone, why would you not give it? I don't see a reason why. Why is the debate even there? It's very clear that if she were to have a natural age of menopause, she'll have her hormones till the age of 50. But right now, this is not there. So clearly, you need to replace. Now, I'll tell you an analogy of this, and this is something I often tell in my talks. If, let's say, a man has hypogonadism at the age of 35, so he has no testosterone or has reduced testosterone, or for whatever reasons, it could be because of maybe some surgery, or it could be because of mumps, or it could be because of Klinefelter syndrome, which is again a condition which leads to early hypogonadism in men. If you have any of this condition, if a man presents with hypogonadism with testosterone levels which are on the lower side, tell me one man who will refuse testosterone treatment. Nobody. I have never seen any male patient refusing hormone replacement for men, right? Nobody would say no to it. In fact, there is no debate at all. There is absolutely no debate in that field as well. Again, I often see, in fact, on the contrary, I often see men with slightly reduced testosterone, which could be often attributed to other causes, requesting, in fact, literally begging, literally fighting that I prescribe them testosterone because they are hypogonadal, right? This is so common. So when you have a woman clearly with menopause, with an early menopause, clearly having POI, and we are not even debating. Why are we debating this? There is no question. These women need to be treated. There is absolutely no doubt about it, right? Of course, barring contraindications, but in general, there is clearly a role for it. Menopause hormonal therapy, you have one aspect of treatment which is there. Of course, you will have fertility as an issue. So if you have fertility issue, that needs to be again sorted. And of course, educational and psychological counseling and support, which is very important. What are the options for menopause hormonal therapy? You have in those women who have, let's say there is no uterus, then you can directly give estrogen. You don't need to give progesterone. So just estrogen alone can be given in women without a uterus. But those women having uterus, you need to give estrogen plus progesterone. Generally we prefer 17 beta estradiol or estradiol valerate for treatment. You have conjugated CE, which is also available, and these are the ones. And you can use transdermal estrogen. Don't use, again, a request, please do not use ethinyl estradiol. So do not use your conventional OC pills for treatment with these women, because the ethinyl estradiol has no effect on protection of the bone, right? So one of the aspects of treating these women is to protect their bone as far as osteoporosis is concerned, and ethinyl estradiol does not protect the bone. So your regular OC pills do not have bone protection, whereas a standard hormone replacement which has estradiol, valerate or ethinyl 17-beta estradiol, that is the one which will protect the bone. You can use micronized progesterone or you can use combined pills, but again, like I said, OC pills are not an ideal treatment. And some women who have low libido, testosterone therapy has also been very low dose of testosterone, generally 50 milligram has been shown, but of course this is again an area of debate. I am generally not a big fan of testosterone treatment. I'll tell you right at the outset. I don't want, of course this is an area which has been a lot of controversy, and there's an Endocrine Society guideline also for this, AACE guideline also for this. But I think as far as my personal opinion is concerned, I generally do not give testosterone. In fact, a good HRT often improves the libido also. Right. So there is now there's a study called Poi Study which has shown, and this is what I was talking about. In this is a multi-center trial where there were two groups. One was given a standard hormone replacement therapy, another was given a combined OC pills. And what they were looking for was the impact on bone mineral density. And you can clearly see from this treatment, the combined OC pills. This is the purple is the no treatment group. The red is the one where combined OC pill was given, and the green was where the HRT was given. And clearly you can see standard hormone replacement therapy did better as far as BMD is concerned, but there was decline in BMD with both OC pill as well as no treatment. So again, combined OC pill containing ethinyl estradiol does not protect the bone. I am repeating this again, it does not protect the bone. So a OC pill is not a replacement for hormone replacement. That is the thing you need to understand. There are other considerations you have to keep in mind. Patient's preference, the route of administration, optimization of other factors like vitamin D and so on. These patients need regular review. 17-beta estradiol is preferred over ethinyl estradiol, as we already discussed. Again, it has benefit in terms of bone, but also blood pressure. Also, there is a benefit there. In fact, Turner syndrome, your standard OC pill is relative contraindication. These women tend to have renal dysfunctions, higher risk of hypertension, coarctation of aorta, higher risk of developing aortic aneurysm and so on and so forth. So aortic dissection. So all these women, Turner's women should always be given standard hormone replacement and not OC pills. So overall, there is some again debate on androgen replacement. Some people prefer DHE as replacement, which is again not a standardized preparation in our country so far. Again, testosterone replacement is an area of debate. What about infertility? Again, I'll not go into too much detail of this. I'll leave it to the fertility experts. There is always hope, and again, FMR1 premutation must be done in any of these women where you are thinking of fertility. Cognitive outcomes are improved as far as hormone replacement is concerned. There is a benefit there. Again, this is an area where you need more nuanced approach and something which you need to look at. Again, emotional health. A lot of these women are, by the time you see them, they are already on SSRI given by somebody, a physician, a psychiatrist, a family doctor, and so on. And again, you need to understand the etiology of the mood swings, etiology of the emotional health, and I think the POI is the etiology and not the patient having actual clinical depression. So I think that is something again which needs to be kept in mind. When you talk about post-pubertal or pre-pubertal treatment, again, post-pubertal, like we already discussed, the standard treatment is they require higher doses of estrogen, typically 2 to 4 milligram, as we discussed, of estradiol, 17-beta estradiol. Again, all these women with a uterus in situ need to have a progesterone also. And we'll discuss this in a few minutes. Pre-pubertal women, again, initially we start this. So when I talk about pre-pubertal, I'm talking about Turner's. So when you talk about Turner syndrome, we start with the lowest possible dose of estrogen, of estradiol, valerate or 17-beta estradiol. Gradually, initially for the first 2 years, we just give estrogen. And after 2 years, once you have breakthrough bleeding or when you have adequate breast development, after that we add progesterone, and then the patient has normal menstrual cycles after adding progesterone. So we give estrogen plus progesterone, but first we give estrogen and then we give progesterone. Okay. Again, this is the global consensus, is what I talked about, the global consensus on testosterone replacement. And again, meta-analysis has shown that available data show no severe adverse effect of using testosterone. However, like I said, it needs to be done right, and it needs to be done in very selected patients. Then it's useful. It should not be given to all women. It's an area again of significant debate. With those women with special issues, women with Turner syndrome, like I said, in Turner's women don't give OC pills. These women need standard hormone replacement. Women with POI with BRCA gene positive mutation or having breast cancer history, HRT is generally contraindicated in breast cancer survivors. So already had a history of breast cancer, you don't give it. But those who are having BRCA mutation without personal history of breast cancer, they can be considered if they have already undergone a prophylactic bilateral salpingo oophorectomy. Right, so this is one. Women with endometriosis, for those women who have already undergone, who required, we already have a lot of these patients on our follow-up who have undergone oophorectomy, can be given can be given HRT. And those women with migraine, of course, migraine is not a complete contraindication for use of HRT. Again, you need to individualize the approach. Again, other special issues, women with fibroid, it's again not a contraindication to use. And again, if possible, you should consider using transdermal route for obese women. Women with hypertension, again, not a contraindication. In fact, the modern estradiol valerate or 17-beta estradiol does not increase the blood pressure. So again, something very useful. Women with history of VT, this is something very important. They need to be evaluated. What is the reason for thromboembolism, that needs to be known. And they should be, managed. Of course, a hematologist should be kept into consideration. But in these women, transdermal preparations are very safe. In fact, transdermal preparations do not increase risk of thromboembolism. Okay, so overall, this is what we have available in our country. We have a combined hormone replacement therapy treatment available. There are two forms of it. One is sequential and other is continuous combined. This is going to be discussed in detail in the next talk, so I'm not going to discuss in too much detail, but just to tell you briefly, for younger women, we can consider a sequential therapy where you have initial 14 days just estrogen and the next 14 days you have estrogen plus progesterone pill available. In postmenopausal women who do not want periods, these women can be given estrogen plus daily progesterone treatment. Right? Fertility preservation options, again, we'll not discuss in too much detail. Again, we'll leave it to the fertility experts to deal with this. Again, the benefits of HRT, you have benefit in terms of vasomotor symptoms, genitourinary symptoms, bone health, cardiovascular health, sexual function, improvement in life expectancy, quality of life, and neurological function. All of these you have improvement. Okay, so just to summarize, just a second. Yeah, I think there's some echo I'm getting. Yeah, so just to summarize, women with POI, it is very important, couple of things you need to take home. So important take home messages which you should consider. First and foremost, call it as a premature ovarian insufficiency. That's the current terminology which you should consider using. Second important thing, autoimmune disease is a very important etiology for POI. And again, if you have a woman with autoimmune POI, you should consider, looking for adrenal insufficiency, which is again important consider here. And all women with POI deserve treatment. They must be offered treatment and they must be given till the age of natural menopause. So I thank you for a patient listening. Thank you.